Hello everyone, my name is Professor Peter Nash from Griffith University in beautiful downtown Brisbane. Welcome to the CSF Rheumatology Author Interview Podcast. Today we are extremely lucky to be joined by Professor Georg Schett from the University of Erlangen-Nuremberg in Germany. So thank you, Professor Schett, and welcome, and thank you so much for your time in the middle of this difficult period. We'd much rather be seeing you face to face than over the internet. But today we're going to discuss a recently published article by Professor Schett's group in Nature Communications, which looked at COVID-19 infection, particularly in our immune-mediated inflammatory disease patients, and observed a reduced incidence of seroconversion in those patients. So welcome, Georg, and just tell us a little bit about how the COVID epidemic's going in Germany at the moment, cases, lockdown, how it's changed your practice.
Yeah, thank you, Peter. Very nice to see you. COVID-19 actually hit Germany in spring, starting in mostly March, April, with a strong decrease then in May, and now it's pretty fine. The overall prevalence was much lower than in other European countries, for instance, like in Italy, Spain, or in the Netherlands. Basically, because the lockdown was done very early and quite rigorously, and therefore there was no increased death rate in Germany with respect to COVID. So the usual death rate increases in winter in all the European countries, mostly because of influenza and other infections. And COVID added to this this year, but in some of the European countries, mostly probably based on a strict lockdown, this excess death rate didn't happen. So with the same economic problem we all have, but in a way, the prevalence of COVID in Germany was rather low. Yeah.
I was just going to say, have you seen a second wave like we have in Melbourne?
Well, there is now I wouldn't say it's a second wave. There are very local outbreaks, mostly in slaughterhouses, which are owed to the fact that people after the lockdown went on holidays, came back, and a single individual is often sufficient in a certain environment to infect many others. Slaughterhouses were particularly prone for outbreaks because of the low temperature and the air circulation. So there was several outbreaks in slaughterhouses, basically shutting down them with 50 to 100 cases. So these are very local things. Also, some places in touristic areas, small outbreaks in hotels, but they could be tracked and controlled rather easily. So I wouldn't say it's a second wave. It's not like this kind of big wave we had in spring. It's a little bit different now, I would say. Much more patchy.
Okay. And can you tell us a little bit about this study that you published and how and why? We've been involved with COVID-19 Rheumatology registry around the world, and EULAR has one as well. So can you tell us a little bit about that registry and then about this study?
Yeah, well, I mean, the registry is mostly based to collect COVID cases in patients with rheumatic diseases, which is, I think, a very important endeavor in a way to learn whether the COVID cases are different in patients with rheumatic disease, especially due to the therapy. Meanwhile, there are a few good publications from Italy and also from New York by Jose Scher, for instance, showing very nicely, and also a few good studies from China with respect to Crohn's disease, that there is no change, no more severe course of COVID in patients with autoimmune diseases, mostly data on Crohn's disease and rheumatoid arthritis, which I think is very important because originally people thought that these people are a risk population, and they would have probably a more severe course. And all the studies so far didn't show that, which is very reassuring, I would say. As said, these are studies collecting COVID cases with a background of autoimmune disease.
So can you just update us on which cytokines are involved in COVID infection? And then we'll talk about the study itself.
Yeah, so what is thought that COVID, as you know, is infecting alveolar cells type 2 with having the ACE2 receptor, and also gastrointestinal epithelial cells having the ACE2 receptor. And after viral entry, and that's similar with SARS-CoV-1 and SARS-CoV-2, there is a production of cytokines, mostly innate cytokines, by the epithelial cells, leading to the attraction of neutrophils and macrophages into the alveolar membrane. So there is IL-1, TNF, and IL-6 involved. And the influx of neutrophils and macrophages is actually the problem of severe COVID, because it leads to clotting of the alveolar membrane and therefore respiratory insufficiency. At the same time, there are cytokines activated which are involved in viral clearance, for instance, interferons as well.
Okay, so tell us about the study, how you went about it, and where you got the patients from.
Yeah, so what we did is we started quite early in the year to do antibody tests in patients with immune-mediated inflammatory diseases. So we teamed up with the gastroenterologist and the dermatologist with respect to Crohn's, ulcerative colitis, psoriasis, and then from our side, rheumatoid and spondyloarthritis, and collected actually all the patients are taking cytokine inhibitors. So they were about 400. And then we collected patients who were not on cytokine inhibitors, which were on classical therapy like azathioprine in gastroenterology, methotrexate in rheumatology, and in dermatology also mostly methotrexate. And then we had some control populations, which were predominantly two control populations. One was a control population of the normal individuals. So we had collected a cohort of healthy individuals from the same region. And we had a cohort of hospital employees or employees in healthcare, which is not only hospital, but private practices all around. So we compared basically the seroprevalence in these four populations, and also compared exposure to infections, and we compared also symptoms. Yeah. So bottom line, what was quite interesting: first, prevalence of infection with the new coronavirus in Germany, in our region, was 2.2%. So this is rather low, yeah. And when you compare, it's in Austria about 5%. It's in Switzerland, in Geneva, it's about 10%. And in high-risk areas, for instance, in Ischgl, which is a ski resort, or in New York, it's about 40% seroprevalence. So overall, the seroprevalence in Germany is, and Bavaria was the most hit area, is only 2.2%. When you look at hospital employees and private people in healthcare, it's doubled. Yeah, it's 4%, and that's mostly due to a higher exposure rate. Yeah, so when you ask the people, they have a higher exposure to people who got infected, which is logical. So in a way, hospital or healthcare employees are a certain risk population to have a higher prevalence of COVID or a coronavirus infection. What was quite interesting and that was actually the most interesting part of the study, that people with taking cytokine inhibitors had a prevalence of less than 1%. And that was quite interesting. You could say, well, they are scared, they don't expose themselves to others, and they lock themselves at home. But we actually carefully looked at that, and that was not the case. They were not more locked than others. Yeah. So the pure lower exposure, we don't think it's a good explanation. What we think is that they have, when you have a virus or any infection, you have an adjuvant effect by the inflammation. So that creates symptoms, but it also creates antibodies, like in vaccination. And what happens when you take such drugs, you blunt that response. So you get less symptoms, and you get actually no antibodies. So we don't think that the cytokine inhibitors block viral entry. Yeah, that would be odd. But I think what they do is they block the inflammatory response to the virus upfront, yeah, because it's an exposed individual already,
Right.
cytokine inhibitor exposed individual where the virus comes in. So that's our most likely explanation for it.
Right. And look, we're used to PCR tests to diagnose this virus. Tell us a little bit about this antibody test, cross-reactivity, robustness of that test, and whether it tells us about infection or colonization or just what?
Yeah, well, I mean, I would say an antibody test is like with any other microorganism. It tells that the host has been exposed to a certain microorganism, and the microorganism could trigger an immune response. I would think it's more than just colonization, because you would need to actually expose the immune system to it. So I think I would say it's an infection, but infection could, of course, also be without any symptoms, as we know. So that's part one. Part two is there is always the discussion how much there's cross-reactivity with the human endemic coronaviruses, which are mostly making mild infection in young individuals and are basically there every year. So there is very little cross-reactivity, I have to say, because we did actually, we also cross-tested serum samples from such individuals from 2019, where there was no SARS-CoV-2 here in Germany, probably not all over the world, there was no SARS-CoV-2, and they were showing a very different pattern. Yeah, so we are quite comfortable to say that the antibody test really picks up SARS-CoV-2. It would also pick up SARS-CoV-1, but SARS-CoV-1 is gone since about 14 years and it was not prevalent in Germany at all, just in Canada and in Asia. So we are pretty comfortable that we measure really the right stuff. I should also mention, Peter, is the fact that we have a COVID prevalence here in Bavaria of 0.3%. That means 0.3% of the population walked into the doctor, got a swab, were positive for RNA of SARS-CoV-2 and had symptoms. And that's 10 times lower than the antibody prevalence. So that means that 9 out of 10 individuals, they don't have much symptoms, don't even realize that they got coronavirus infection. It's quite interesting and fits very much to Swiss data, where they showed actually that they have 1% prevalence of COVID-19 and about 10% antibody positivity. So it's 1 to 10 in a way.
And that goes with, of your positives, 13% went on to have a positive diagnosis of COVID. So by far, being asymptomatic is much more common.
Much more common, and we also tested how many actually of our tested got a diagnosis of COVID during the study, and they were actually, it's 1 out of 10. Yeah, so it's quite interesting that we underestimate by RNA testing. Yeah, we underestimate the prevalence of the disease because it's only a short time when you are RNA positive, whereas you have it's like an HbA1c when you take the antibody test. Yeah? What happened in the last?
They're there a while.
Yeah.
Why do you think they've had so much trouble proving tocilizumab, sarilumab is effective then? Recently, anakinra came up well. They've had real trouble proving that anti-cytokine therapy is effective in either prevention or treatment.
Yeah, yeah. I mean, I just saw the negative outcome of the tocilizumab study, if I'm not completely incorrect, yesterday or a few days ago. And that was, I would say, surprising because most of the people thought that it would help. I think the challenge is always when to start such a treatment. Usually, if you start it in a rather later setting, maybe you cannot reverse that easily. So I think there's still some work to do, I think, but I think the challenge is always when to start a cytokine therapy, then anti-cytokine therapy, that it would be effective. Yeah. So that is, I think, the big problem is all sepsis things, and in a way, it seems that SARS-CoV-2 is not very different. Yeah. But what I also think what we have learned by these studies is one part. We give tocilizumab or other drugs in a severe infection for treatment. Yeah, and I think it's very courageous, you know. And as we as rheumatologists, we're always scared by infections. So now the people change their mind completely and give it a severe infection, and that's amazing. So what it tells us, I mean, when somebody with a rheumatic disease under tocilizumab has a coronavirus infection, we probably don't even stop because it's not adverse. I mean, the study showed even a little benefit. It didn't make the primary endpoint, but it didn't actually kill the people. So it's quite, I mean, it's a really a reset in our mind. And I think what it shows that the cytokine inhibitors, they foster a certain infection profile. Yeah, you know, with secukinumab IL-7 inhibition, it's Candida. With TNF, it's TB. Probably with IL-6 inhibitors, some bacterial infections, but it's not actually a respiratory viral infection, which is, I think, which is very interesting. And I think that's a strong learning curve in this half year, what happened, how we interpret infection risk with anti-cytokine inhibitors.
Well, I must say, I've discussed this with Kevin Winthrop, an ID physician in Portland, where he says he's surprised how few of our patients are winding up with COVID infection that he has to look after, which fits with what you've found. Do you think the JAK inhibitors are different? They're talking about interferon as a therapy. If anything is going to promote viral infection, the JAKs should. There's talk of Barry as a treatment. How do you think we should treat the JAK inhibitors in the COVID situation?
Yeah, I mean, there has always been a little more concern with JAK inhibitors because they also have a strong inhibition of interferons, as you know. And the other part is that it's the only drug where you see a clear signal with reactivation of virus, with herpes virus, which is it's a very different thing. So there's been probably at the beginning more concern with JAK inhibitors, but there are no really data that JAK inhibitors would actually change the course of the disease of COVID. So in pre-treated patients from the registers, that's number one. In our study, we had also substantial numbers of JAK inhibitor treated patients. We didn't see that they behave differently from the cytokine inhibitors. So that's also reassuring. And as far as I know, there are JAK inhibitor studies ongoing in COVID, right? And I don't know about the outcome, but at least that they have considered to do that is I would say it's a courageous endeavor, but it may be also correct to do it because it's a strong inhibition of IL-6, which and also the GM-CSF component, which has also been shown to be important in COVID. So the inhibition of innate immunity might have an effect, but we have to wait. I mean, we don't know about that. So I wouldn't be that stressed with the JAK inhibitors at the moment. But of course, we need more data, as you know. So that's a very preliminary thing.
All right. So tell us a little bit about the prospects of a vaccine. If you get immunity, how long might it last? And then, do you think there are mutations in this virus that mean a vaccine is going to be difficult?
Yeah, but it's very difficult to predict that. I mean, there's a huge effort to make a vaccine, which is logic because the economic impact of this virus is unprecedented. And of course, I mean, the vaccine would be the best option to control the virus in the long run. First, I think the good thing is very clear that the spike 1 protein is a key antigenic part because most of the immune reaction is against the spike 1, which I think is a very logic thing. So the vaccine will be based on that, and there will be many vaccines coming up. So the key question, what we can't answer at the moment, is do you get enough neutralizing antibodies? Number one, and how long do the antibodies last? So I think at the moment there are no answers on that. For the duration of antibodies, I would be very skeptical that we would have a very long duration of antibodies. Why I say that? Because I think the key, there are two data sets which are important. One data set is from SARS-CoV-1, where the virus 15 years ago, when they retested over the time the antibodies, most of the antibodies are gone after, in most of the individuals are gone after 5 years. So it's not like measles where you get one shot and you're fine for your life. That's very unlikely, because usually a vaccine does not make the same strong immune reaction than the viral infection. So one would assume that if you vaccinate, that you would get probably neutralizing antibody at best, but then they would fade away after, let's say, maybe 2 years. Nobody knows that. Yeah. So that would mean that you can overcome with a yearly vaccination. Yeah, that would be possible, because we do that with influenza based on mutation. Also and the second data set is the Chinese data set, that they looked at SARS-CoV-2 antibodies over time, and many people actually lost the antibody response. So I think it's a non-permanent antibody immunity. So you can get reinfected probably when you lose the immunity, and that has to be addressed in vaccination studies at the end. Yeah, and the other part is, hopefully you get neutralizing antibodies, and nobody knows that for sure. I mean, the first data look quite positive. So let's hope that this will, it's a really important program, and I think the whole world hopes that this will work somehow. Yeah.
Excellent. So to finish, just a take-home message for the clinicians from the study that you published.
Yeah, well, don't worry about the coronavirus. Continue treatment. That's that's a very important message, because when we started here, we got so many people who were completely worried to stop their treatment, and because they are at risk, and we didn't know at the beginning. Honestly, we didn't know. So now, after all this data, it's very reassuring that we should not say don't stop the treatment. Yeah, continue the treatment, and if you have the infection, it's an individual decision. But I think what the message is, we should put out the stress of our patient, that they are at particular risk for this infection, and I think that's the most important message.
Thank you very much. Look, we thank you again for your time, Professor Schett. This has been the CSF Author Interview podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast or on iTunes or wherever you get your podcasts, and let us know what you think with some feedback. Thank you so much for your time.